Together.
Hey, you guys did it. You talked it out, but let's talk about it because we heard some talk, which was the perfect talk. Like, why the heck is infection the last priority? Right? This isn't burns. So you all rewrote history. You all saved your patient, right? So that's great. Did anybody have any trouble with the total body surface area of the burn? Did everybody get that right away? 63% right away? All right, so what is the difference between partial and full fitness, you think? Which is worse?
Full.
Full. Which is going to need grafts? Full. Which are you not going to have pain? Full. Why no pain in full? It's beyond the burn, it's beyond the nerves, okay? So if somebody came in and they were that's going to really control how much pain medicine you're giving somebody to know that they're partial or full. Is that all? Wait, no, one more? Yeah. What's yours? Minimum. Okay. All right, now the total volume, the fluid resuscitation, the Parkland formula. Do you have to memorize that for the exam? No. But here's the thing. It's wrong in your book. And I want you to realize it's wrong in your book. The book forgot that little tiny thing about multiplying it by the TBSA. Okay? So the Parkland formula that you got in that scenario was the right one. It's 4 milliliters times the total body surface area times the kilograms. Okay?
So you say we don't need that?
You don't need to memorize it. It's not going to be a question, but you need to know. We made the fluids like a big part of it, but not the biggest part of it because we thought you might all go there because of Josie. You all know it's a big fluid and electrolyte tank, right? We said in the report that the lactated ringers were warmed. Why were they warmed? Not
vasoconstriction.
Hypothermia is huge in burns. What was the patient's temperature? 96. And if we start putting in cold IV fluids, what are we going to do? We're going to drop it further. Okay, so we have to maintain that person's temperature. They're already hypothermic. Okay? So that was that about it. Anthony, did you have a question?
We didn't win, but for what it's worth, we finished in 32 minutes. Or we had 32 minutes.
Oh my
left.
God.
We finished in 28.
Which one were you?
Yeah, read 28.
Is that the time that was supposed to be left?
Time left.
We had
They had
32
32
minutes
left.
left.
That's not what she said.
She said we finished in 28 and then had 32 minutes left.
You really want that?
That's ended up to be
She's a little confused.
You guys have 13 minutes left?
I thought it was 23.
We had 23 minutes.
We weren't that bad.
No, because you had it here before, so that's not right.
32 remaining, you're right. You want the remaining.
What did you write on your paper?
Oh.
23
And minima is 23, 38.
23, 38. Okay. All right, so there are the totals. So, Professor Foreman's group, come on down and get your trophies.
I'm so excited.
And your pictures. Right and right.
Thank you. I'm sorry.
They're very high quality. Wait, gotta sit here because you need an interview. You're welcome. See, now you guys can say I earned a trophy in nursing.
Look at those cakes from
All right.
I want a participation trophy. I don't even have to do cookies.
She's always
Hey, we got
Okay, now why we're taking pictures? 1, 2, 3. Why we're taking pictures? All right.
Somebody else.
All right, you guys. So we're gonna have Miss Lefko come over and take a group picture with all of us in it. This is the last day I have y'all. I was playing. So today's a really blessed day. So you guys are going to Dr. Perry and her church. You are no longer
terminal either? Like this is seriously.
No, I'm seriously first and second term, first year.
You don't like pop in?
But I'll pop in.
about
when
like
y'all see me.
like-
Like I'm like, I reemerge. You think you're done with me? Get out of that.
You want me to just like grab
I
some?
volunteer to take it.
I'll send you a snap.
All right. So let's talk a little bit more.
Don't tell.
All right.
One Thursday when I'm crying.
So the communication thing with the live with you guys, where you had to communicate that the patient was confused. I was in Dr. Schlereth's room. They did it like that, okay? So that was great. So I actually saw a video of that on Facebook, and it was a guy driving a motorcycle, and by the end, it was somebody doing the cha-cha.
Yes.
Okay, but it shows you like the breakdown in communication. If we forget or don't communicate well that the patient's becoming confused, what was that a sign of? Shock. And what else? What else was really going wrong with the patient? What was their biggest priority? Oxygenation. And so it was a sign of hypoxia, which honestly we pulled that from that exam question that we nullified last time. You know, remember your patient was getting like confused and lethargic, and your right answer was an ABG. So I will tell you that I pulled a lot of the scenario, and I changed names, and I changed ages, and I changed some values from your book. If you guys complete the nursing care plans and the relates and the how-tos and the whatnot, you're applying that information. That is the best way you can study. Those answers are on my nursing lab. You have access to the answers. Okay? So I just wanted to throw that out there. So your focused assessments. The things, the top ones that you needed was the urine output. Why are we worried about urine output? Dehydration, but what am I worried about? Organ failure, shock, perfusion, shock, perfusion. That's why we have to fluid resuscitate, right? And all that fluid is shifting. So what could occur? Somebody gets burned, the fluid starts to shift. We give LR for what reason? What kind of fluid is likely to reduce? Isotonic, where does it go? It stays in the vascular space to help increase perfusion and blood flow, okay? So the way to measure if that's working is urine output. What is your guideline for urine output to know if it's okay? 30 milliliters an hour is the old way. That's the old way. What's our new way, more accurate way? 0.5 mLs per kilogram per hour. Okay? That is patient specific. Very patient. Because it's put on this hour. So if you have a test question or something like that you got to figure out, it's 0.5 milliliters per kilogram per hour.
Where does the LR?
Okay, so you have to do a little bit of math. So I know that I messed up your ABGs and I couldn't remember them off the top of your head, but your next ABGs were what? They were tanks. So what did that patient need?
We never got ABGs.
Yeah, we did.
They should have been on the yellow
It was on the
card.
card.
Oh, was it? Okay.
What did that patient need? He needed to be intubated. Or she. It was Angelica. She needed to be intubated. Right? So that's why your first intervention was called a healthcare provider, because we don't intubate. Okay, so that's why that was number one. Did any of you guys have trouble getting that one as your number one? No? You all did it. You all know. So okay. Guys are a step ahead. Patient's current pain level was still what? 9 out of 10. And with somebody in that much pain, it's not helping respiratory effort. It's not helping anything, right? Patient's current vital signs. What did the blood pressure, the heart rate tell you? It was the blood pressure was lower, the heart rate was high, shock, perfusion, right? When we give all that LR and we try to go in at the right rate, which should have been 914, I think, off the top of my head, and it was at 500. If that's going at the right rate, blood pressure should go up, heart rate should come down. So I saw one group do the flag on the play part where you had to put the flags in the right order. So oxygenation was the biggest. That patient needed to be intubated. Okay? But here's the thing. So what do we look for in a burn patient? A lot of times we preemptively, if they have burns and they have singed nasal hairs and they're hoarse and everything, they'll just go ahead and intubate in the ER because it can rapidly get much worse, which it was in this patient, okay? So a lot of times, even if they don't have to right that second, they will go ahead and intubate and sedate that patient and maintain that airway, okay? So hoarseness, singed nasal hairs, anything like that are clues that you got to be really careful. The patient had burns to their back, okay, and their arms, so we know that it was close. All right, so you have to be really careful. So oxygenation was your key there. Okay, if we lose that airway, they're dead. They die. That's what kills the patient. But you rewrote it and you saved them. All right. Fluid and electrolytes was your biggest one. The next one, because we have to get those fluids at the right rate, increase their perfusion, decrease their risk of shock. All right, so risk for infection. We've heard, why does infection last? Is infection going to occur 1 to 5 hours after they hit the door? No. Okay? So this is why when everybody's like, just tell us what the priority is, Dr. Pritchett. I can't. Because what's going to be the patient's priority 4 days from then when we fluid resuscitated them and we have their airway good? Then there's going to be risk for infection. Right? So that's why it depends on what's going on with your patient. I'm absolutely worried about infection, but right now we have to keep their airway open and their organs perfused. Okay, does that make sense? Why? Imbalanced nutrition. A lot of times, you guys remember when we got to interventions, put an NG tube in, right? Because we're going to have to give them, depending on how bad the burns are, put an NG tube and do enteral feedings. Okay? Nutrition is very important in our burn patients. We have to make sure it's good. And they're about to be ventilated. What do they need? High protein,
High
calories, right? Okay, good. All right. The puzzle part where you had to give outcomes, how was that? I didn't see anybody do that.
That's cool.
Easy peasy, lemon squeezy? Okay. How is it when you're doing it with your patients in the clinical setting? Any of your clinical instructors say, so what do you want to happen for this patient today? Slide me, they do too.
Yeah.
Yeah? Okay. So what kind of markers do they put on it? We didn't make you do SMART goals, but okay, let's make one for this patient right now. SMART goal for airway, for Angelica. So SMART, S is what? Specific. What do you specifically want to happen with her airway? Maintain apparent airway. All right. A is what? Oh, I did forget an M. I can't spell off the top of my head. M is measurable. How do we measure that?
By what time?
Well, that's T. How do we measure?
Oxygenation status.
Oxygenation status. We can put ABGs in there. Their work of breathing in there. That they're intubated. Okay. A, attainable. Is keeping an airway open in this patient attainable? Can we do that?
Yes.
Is it, and R, realistic? Is it realistic? Okay, so most of the time in clinical or in class, when I say write a SMART goal, realistic, people will be like, I want their cholesterol to decrease by 300 points by the end of the shift. That's not realistic, right? It would take me about 18 years to decrease my cholesterol like that. All right? So when we want you to write outcomes, and we're going to be working with our clinical instructors to make sure that that's happening, if you don't know what you want to happen for your patient, then how are you going to give them the care that they need? And that's one of those steps in the nursing process that's honestly overlooked too much. Okay? So think about that when you're answering test questions. What is it I want for this patient? What is it I want to happen? That will help lead you to the appropriate priority nursing intervention. If you can say to yourself, what is it I want? Okay. All right, interventions. You guys had to call the healthcare provider, prepare for intubation, fluid resuscitation, then your I's and O's. What are your I's and O's telling you? Why is that so high up the importance scale?
We want to make sure that fluid resuscitation is working.
You have to make sure the fluid resuscitation is working. What is their urine output? Administer IV analgesics. Are we going to give them a PO Tylenol?
No.
That's spitting on fire.
Sorry, friends.
Right? They need the good drugs. Fast. Okay? Place nasogastric tube for what? There's two reasons, nutrition and suction, if you need it. But it depends on which nasogastric tube that you're using, but yeah. Okay? Wound dressing changes as ordered was all the way down on 7. I'm absolutely worried about it, but that's not my priority. My priority is still their airway. So what the big thing I want you to take away is it's burns, and everybody's worried about the skin, and they think the skin is the most important thing, but burns is multi-system. It affected your respiratory, your perfusion, your comfort, it affected all those fluid electrolyte balance. It's multi-system. Okay? So we have to really see which is going to kill them first. What killed that patient is their airway. Followed closely by the lack of IV fluids if they need it. Okay? Wasn't the skin. Yes, ma'am.
Can you explain why the airway was compromised? Like, was it from like smoke inhalation? Was it from?
Yeah, so it causes swelling within the airway.
From
From the smoke.
Okay.
From the smoke. So when we see like singed nasal hairs or that hoarseness, there's airway damage there. It can cause swelling, stridor. What other questions do you have? You guys are good. Nobody can? Oh, Trina.
The photographer's here whenever you're ready.
All right, let's take a picture. Here's our picture. Your parents love to see your pictures from nursing school, don't they?
Yeah.
All right.
I always show my mom. I don't even think I've told my mom. Putting my
Squat. You can share a seat with me if you want. Squat. Share a chair. Squat.
There we go. I'm good.
I'm not that big.
I'm leaning.
Just take that.
There we go. I'm good.
I'll give you my chair for some extra points then.
Not in charge of this.
I'm just kidding.
All right, she's that way. Everybody look that way. All right, thank you.
tried, Amber. I give it a
So I don't even know who you are yet.
That's a good thing. Okay. Yeah. You have no idea. My addresses.
She's working Alan Jackson. That's all you need to know.
One more thing. You guys are one competitive bunch.
Yeah.
But the reason we were timing you, and I think the escape room works so well here for this, is what happens when you're hurried. You make mistakes, right? And so think about back to your time when you were really trying to prioritize and stuff. Were you taking the amount of time that you needed to, or were you like, we got to get out of here, we got to get out of here, we got to get out of here? Because that happens in nursing. I have made nursing errors because I'm in a hurry. Okay, that hurts people. So I like the escape room because it kind of gives you a little bit of that. Like, we're in a hurry because we want this plastic 30-cent trophy. Spent a lot of money on these.
I got one yesterday.
But that's what I'm saying. All right, so
You
take
got another one.
2, 3.
Let's just keep going.
So let's talk about the PICO stuff first. So you had this in 133. How many of you have written a PICO question this semester? Yeah, I got to get after my clinical instruction. Really, that's what you should be doing. Every week you should be writing a PICO question. Has no one had something in clinical that they thought about, oh, why do we do that this way? Nobody's had that? Yeah? Okay, give me some examples. That's just a stupid medicine error. But that's a good question. But that one's really like, okay, but that's standard, that falls under standard protocol, but that's, you're right, dumb, more, but not a question. Anything else you all had that you were like, why do we do it this way? Why do we do it this way? How many people had patients with wounds sometime during the semester? Post-op wound? Post-op wound? Okay. So how many people changed the dressing on a post-op wound? No? Nobody changed the dressing? How about on a decubitus ulcer or some kind of wound? All right, changed the dressing on it. What'd you do to it? How'd you change it?
I took the dressing out.
Okay, not every step by step. Just the synopsis. What'd you do? What'd you do when you took the dressing off? And what'd you put back on?
Looked at the wound.
Okay.
And then packed the dressing in.
Okay, so you packed it with what?
Saline soaked.
4x4s?
I guess so.
Okay, so it was a wet to dry dressing?
Yes, yes.
Okay, so it was a wet to dry dressing. Why did you do it?
Why? Keep the wound in.
But it's going to be wet to dry.
Frequent dressing changes.
Because a wet to dry dressing, then essentially the 4x4 dries in the middle, and when it dries in the middle and you pull it out again, what do you do to the dress? What do you do to the wound? You debride it. Okay, but so why did you do it? Why did you do that specific type of dressing? Are there other kinds of dressings you can do? So why did you do that kind? So that's when you turn to the literature. Because thank God nobody said because that was the physician's order, because I would have really just did it then. But, so if you want to come up with a question, so if you want to say, what was wrong with your patient? What was wrong with your patient?
It was just a pressure ulcer.
So a pressure ulcer from a patient in long-term care, admitted from home?
I'm trying to think.
Stretching your mouth.
Yeah. I don't remember what his primary issue was, but I just know he was immobile in the pressure ulcer.
Oh, okay. So in patients that are immobile and have developed a pressure ulcer, that's the patient. Why does a wet to dry dressing, as compared to a dressing with Tegaderm, permit or allow, which one heals the wound quickest within the 6-month time frame? Right? So wouldn't you want to know why did the doctor pick wet to dry versus one of the other types of dressings? So if you have a clinical question like that, and you're in your for term 3, because you're going to be asking these questions and talking about this, and term 4, you're going to be doing a quality improvement project, and you're going to have to develop your own PICO question, collect the data, and do a presentation on it. So it's all preparing you to do this. So when you write a PICO question, now is the time to practice. So if you have, how many have clinical left? Clinical left. If you have something that comes up this week, take it to your clinical instructor. This is, I think, a PICO question that would be really good. Can I look in the literature? Because remember, we looked in the literature before, too. The second handout I gave you talked a little bit about which specific types of PICO questions you can ask. So I'll give this to you again in 242 because somehow, miraculously, all these papers have disappeared from your life. Even though I've given out 133 now, I'll give them again in 242. Unless it snows that day, which it snowed the last 3 times I've attempted to present the topic and got canceled. So maybe you need to find these. Don't lose these papers because they're pretty important. So these are kind of templates you can ask yourself. So when you think about evidence-based practice, quality improvement, the first step is to really write a question with the PICO. Write a PICO question. Think about it. So we just did it off the top of our head based on experience that I can't remember your name has, Jesse, that he had in the clinical area. I don't remember anybody's name except for you're my advisee, and even some of them it's sketch. And that's probably a good thing. So when you think about quality improvement, here's the definition. Combined and unceasing efforts of everyone, healthcare professionals, to make changes that will lead to better patient outcomes, better system performance, and better professional development. So the whole reason we're doing this quality improvement stuff, evidence-based practice, is to come up with, better care, better patient outcomes, right? That's the whole reason. Is this the test question? No. How many test questions do I have? 3. Keep that in mind. Your textbook talks a lot about the 6 aims of quality improvement. And 6 aims for improving healthcare. So you'll hear people in the healthcare arena talk about, well, this falls under the 6 aims. This falls under the 6 aims. In your ATV programs, they'll talk about the 6 aims. Safe, effective, patient-centered, timely, efficient, equitable. 6 aims to improve healthcare. So looking for things that fall under that. This picture's in your textbook. Is this a test question? No. So, when you consider processes, I gotta get my right thing. First, you identify the problem. We did that, right? He has a decubitus ulcer. A look at current policies, protocols, procedures. So, if you think about somebody with a decubitus ulcer or a wound, how many different treatments do you know of? How many besides Tegaderm and Wet to Dry have you guys done? Wound back.
Impregnated dressing.
Impregnated dressing with what's on it?
With what?
What's on it? Impregnated with what?
Oh, like an antibiotic.
Like an antibiotic, okay. The petroleum gauze, okay.
Iodoform gauze.
Okay, iodoform gauze. So there's lots of different policies and protocols for each one of those wounds, right? When you're thinking about it, which one works the best? Then you need to set the benchmark. So what would you think would be the benchmark? So if a patient, Jesse, how long was the guy in the hospital?
Oh, at Carroll, he was admitted probably 2 days before I got there.
Okay. How long do you stay after? Any idea? Did anybody else have him the following week?
No, I don't think so.
So we don't know how long he's going to be there. But so generally, how long would you expect for a wound to heal? How long should it take for a wound to heal? And a patient with decent immunity. 4 weeks, 6 weeks? So let's say 6 weeks. So that's your benchmark. You want to have the wound 90% healed within a 6 weeks time frame, right? Is that a benchmark? So that's a benchmark where we're going to measure which protocol works the best. So when you're collecting data, you're going to see which works the best. Okay. Once you collect the data, you see what's going to make it better. Which one worked, which one didn't. So what are you going to do differently? You're going to try something different? Maybe there's things called variables that are going to change. And then what's going to fix it? And then you're going to implement it and evaluate it. Gosh, does that look anything like something you already know? I saw one person said it.
Nursing process.
Yeah, nursing process. Do you all agree? Okay, so remember, I like nods when you agree with me. Nursing process, you all agree? You get it? You see it? You see nursing process there? Okay. Put the wrong one down. Other terms you're going to think about, other terms you're going to hear when you talk about quality improvement. They're going to talk about auditing a chart. Auditing a chart. So here's my audit the chart story. So when I was a nurse manager, we had the Joint Commission come to see us. And they always audit charts. Always. They go back and look at charts. What do you think was their biggest thing they were looking for? Unrelated to quality improvement. But what do you think is the biggest thing they look at in the audit? Anybody know?
Just like inaccurate documentation.
Nope. How would they know? How would they know it was inaccurate? They're not there.
Who's had access to the chart?
Good, but no, they really don't care about that. Who has access to the facility itself would police that. What's the biggest issue for patients?
Like adverse effects.
We're gonna get to that. That falls under sentinel event. What else in the back? No? You learned it was probably one of the very first skills you learned in 130th grade. Hmm?
Safety, comfort.
Safety, comfort. You can't tie him to a bed rail.
Oh.
Restraints. Restraints. Joint Commission will audit charts to see the documentation on everybody that was in restraints. And if your documentation is not on point, you will get a flag. So that's the best audit example that I can think of. We talked about benchmarks. Sentinel events, we talked about. Who said that? Sentinel events. Adverse
Reactions or complications.
Yes.
from something.
Any, do you know any of them that they are looking for specifically that fall under sentinel
HAIs?
events? Hmm?
HAIs?
Yeah, hospital-acquired infections could be. Are there any specifics you know?
Or like malpractice?
Any specific hospital-acquired infections in the back row with the hat? What's that called? Very good. That's going to be one of your group's posters for term 4. Caudy. What's another one? Not really. MRSA's in there, but not one of the ones that's a sentinel. No. Correct. That's a huge sentinel event, an unexpected death. An unexpected death. So you have, we just had a death in my extended family. You know, when they say it takes a village to raise people, it took a village to raise my brother and I. That's how that went. My father died when I was 10, my brother was 9. And so my neighborhood really was kind of my extended village. And so one of my other fathers just passed away yesterday. And so here we have an 86-year-old guy with a cardiac history who had dead valve reset. They opened him up, took out his dead colon, left him open, put him in the ICU. Okay, 2 days later he was much better. They resected it, closed him back up, didn't put a colostomy in. He was doing great, talking on the phone to his daughter. Fabulous. Died yesterday. So that happened Thursday. He died yesterday. So is that an unexpected death or an expected death? Unexpected. Probably unexpected. They probably would look at that as a sentinel event. Although he has a huge history, and they could probably pinpoint into which one it was. But, you know, a sentinel event is the stuff like the Josie King thing, right? That's what was a sentinel event. It should have been for the facility. The facility should have said, "Ooh, there's a big bell ringing there," right? So that, you know, you want to look for those unexpected deaths. That's very good. Okay, back to the infections. Besides Caudy. The ventilator-acquired pneumonia. Okay, there's one. That's good. That's the one I'm looking for. Collapsing. Collapsing? No? Caudy, collapsing. Catheter line infection. IV infection. Other sentinel events they look for. Now they actually report out most facilities, and we'll talk about this in 242 when we talk about other stuff, but most facilities have to report Caudy collapsing rates. That's something that's public knowledge. So what I told the 4-termers when they interviewed for jobs, I'll tell you the same thing again. You need to ask the question at the facility, what's your Caudy collapsing rate? They'll be like, what? What are you talking about? So, a good question to ask. So the root cause analysis is something that they would do. So let's use my relative of sorts. So, you know, what the facility is going to go, they're going to do a root cause analysis, which they really spend a lot of time and they do a deep dive. And they say, what was the issue? You know, what was the plan? You know, after they do the root cause analysis, they'll do the what was the issue, what happened, what nurse was involved, what physicians were involved. Everybody gets together and talks about it. Truly interdisciplinary if you sit and talk to them. I've sat on groups because I'm a board member at a hospital, so I sat on their risk management committee where they've talked about some of these risk management root cause analysis. So many med errors that nurses make. Shocking. You would be appalled. When I sit in the room, I'm like, please, dear God, let it not be one of my grads. That's all I'm sitting there thinking. But root cause analysis is something else you're going to hear about. And then you're also going to hear about what they call a Swiss cheese model. If you think about Swiss cheese, where they can't pinpoint one specific issue because there were so many Swiss cheese, everything just like kept falling through the holes in the Swiss cheese. So that's probably in your text too. Fascinating stuff when you get into it. Okay. So continuous quality improvement, CQI, that's what most facilities are going for. CQI, which is client data, includes client satisfaction, or patient data, patient satisfaction. They all talk about Six Sigma, which is making sure the quality of care is measured, and then Lean Six Sigma is how they can eliminate waste. So, in the day when I practiced, was the beginning of the plan of care movement. How long I've been a nurse. Anyway, and we noticed that our total knee patients were having a 5-day length of stay. And they got paid for 3 days length of stay. And we kept noticing these trends that our total knee replacement patients were staying for 5 days. And they were, so they did the root cause analysis, and they tried to figure out why were they staying so long with a complication. What was any ideas why they stayed for 5 days? What do you think? Anybody have total knee?
DVT-PE.
DVT-PE? Nope.
Mobility?
Who? Mobility, maybe. Not really. Infection, no. Physical therapy, what about it? Say it again. You're close, but not there.
Early ambulation?
Early ambulation, nope. You answered already, somebody else?
Falls?
Falls, no. Nobody said nausea. I'm surprised. Nausea is usually what y'all say. Nausea, and then they couldn't take their pain medicine, so they couldn't do physical therapy because they're so nauseous they couldn't be in pain. Heard that too? No. You know what it was? PT, and you were close. PT was closed on Saturdays. PT was closed on Saturdays. That was added 2 days to their length of stay. 2 days to their length of stay. And so, what happened? PT opens on Saturday. So, that was fell under that Lean Six Sigma. Eliminating waste. Okay. Now to the important stuff. Plan, do, study, act. Again, does it look familiar?
Yeah.
So, you start with the plan. What are the objectives? What are the objectives? What are the predictions? Plan to carry out the cycle. Who, what, where, when. Data collection. It's a planning end. So really thinking about it, it's your assessment, right? You're gathering your knowledge. You're planning. You're making predictions. This is in your textbook. You're taking a picture of it. Waste your film, my husband would say. Do. Carry out the plan. Implementation. You document your observations, you record your data, right? Study. You look at the data, you analyze it, try to figure it out. You compare your results to your predictions. What did I find? Oh, I thought I was going to find that. Oh, I'm surprised I found that. I didn't really know. Excuse me. And then act. What changes should be made on to the next cycle, on to the next time. Okay? So, in your groups, here we go. In your groups, everybody is going to get Mr. Potato Head. So, which plan worked best? Just to collect the data over a period of time. Because you're going to have to do that. Term 4 in your quality improvement. You're going to create the PICA question, you're gonna have to collect the data, you're gonna have to analyze the data and say, what's it mean to you? Then you're gonna have to create what's called a fishbone. I'm tired, I haven't yet looked. Fishbone, which I gave you all a fishbone. I don't know if there's one out there or not. So we're gonna practice what the fishbone is. So what the fishbone tells you is cause and effect. So these are the causes, and this is the effect. That's all it tells you. It's just a handy way of looking at these are the causes, this is the effect. Okay? So, the other thing I probably should tell you. Is that I submitted this, this whole evidence-based practice piece over 4 semesters is my baby. So the 133 stuff with the PICO, this stuff with you, and 233 you're going to look at the evidence, and you're going to look at the literature. You're going to research whether it's good literature, it's bad literature, and then the 4th you put it all together and you do this big project. So anyway, I submitted it to do a podium presentation at a conference, and so I got picked. So some of your pictures may very well be in that little frame, just FYI. Doing the your video, no cursing included.
Sorry about that.
That's right. I'll edit that out if it's there.
So sorry.
So, yeah, because it's a good thing. I have some 4th semester, 4th semester posters that are going to be there too in the presentation. So that's November. Plenty of time. So what I want you to do, we did that already, is take this case scenario, which unfortunately is on 4 screens because I thought you had a hard copy of it, which apparently you don't, but nevertheless. So I want you to look at this and pair up. Just pair up with whoever's sitting next to you, and I want you to come up with a fishbone diagram. Okay? So you tell me the causes, and you tell me what the outcome is. And then we'll put it together and see what you come up with. All right, so you have Ellie. She's 85 years old. She's admitted for hip replacement surgery following a left hip fracture. She has a history of cognitive impairment and congestive heart failure with frequent exacerbations. Her vital signs were 132, 1/76, heart rate 82, respirations 18. Pre-op CBC indicated all values within normal limits. Chest X-ray indicated lungs were clear. Wait, were you absent the whole frickin' time? Well, geez, so glad that you came in for the last 15 minutes. I appreciate that. You missed all the important stuff. Like what happens in 233. Don't tell him. Let him find out himself. Anyway, the CBC indicated that values were within normal limits. Chest X-ray indicated lungs were clear. Her daughter provided admission history for the nurse. So I'm going to go to another screen. If there's anything important, you need to be writing it down. Just FYI, because there's 4 screens of data, which I thought I said, but it's good enough. Her daughter provided admission history for the nurse. The daughter informed the nurse she didn't have a written list of medications, but could remember them all and all their dosages. The nurse asked the daughter to provide a written medication list to the nursing staff next time she visited. Ready? Wait a second.
Do it.
A medication reconciliation form was completed that included an order for Lasix 20 as well as a number of other medications. All meds were verified with the hospitalist on call and entered into the electronic health record. Unfortunately, the patient's daughter gave inaccurate information to the admitting nurse. Her mother was prescribed Lasix 40 every day. Additionally, the daughter forgot to provide a written med list to the nursing staff. Ellie's surgery was uneventful in that she experienced do you want to read it for me?
No.
Okay, then stop correcting. Experienced significant blood loss during surgery. Ellie's daughter was visiting her mother on the first day post-op when the staff nurse was giving medications to Ellie. The nurse scanned the patient's identification band of medication and explained she was administering Lasix 20. Her daughter informed the nurse that the medication color was different than her mother received at home. The nurse verified the order and told the daughter that she is to receive Lasix 20. Ellie was weighed on the second post-op day with a noted 3-pound weight increase from admission. The weight was recorded in her chart with an indication that a call would be placed to Ellie's physician. Orders were received. Give Lasix 40 PO times 1 now and continue daily weights. Call physician for weight gain of 2 pounds or more. As well, the physician ordered CBC with electrolytes every day. On the fourth post-op day, the patient's hemoglobin and hematocrit were noted to be 10 and 32 respectively, and the physician ordered Tecacross for a unit of packed cells, normal saline at 50 milliliters an hour, and Lasix 40 prior to the blood transfusion. Dr. Smith's orders were written at 9. The IV was initiated at 10. Ellie's nurse was delayed in hanging the packed cells since no IV Lasix was available, and an emergency occurred with another patient. At 1500, Ellie had not received packed cells, and it was noted she was experiencing significant dyspnea. She had 4+ dependent pitting edema. Her vital signs were blood pressure 190 over 110, heart rate 120, respirations 28. Her lungs were assessed and were moist with crackles throughout. The nurse initiated the rapid response team. A transfer to the intensive care unit was planned. Okay? So what's the effect? What's the cause? Go.
I think I missed some in the first one.
You can do whatever you want. See what you can come up with. I'm going to put one on the board for next.
Red color is different, is that important? Does the daughter blend it with the medication goes different than the other?
So this is what you need to check in.
I was thinking 3 pounds. Okay, me too, so I don't feel right. Well, let's start with like the beginning. And then underneath you could put like lost a lot of surgery or lost a lot of blood.
What goes with this? Is that the hip replacement?
The circle would be like that she's getting transferred to the ICU because of the whatever the last What caused them to have all the rapid?